Great. Thank you, Ben Dome and Ben Coons for having me and putting this great program together. Those are my disclosures up. They're uploaded. So when I started my practice, actually things were much easier. I'm going to age myself now. Back in 2002, where we didn't have to worry. The only thing we had to do was just get inside the hip to do a hip arthroscopy for a labral debridement. And as things developed, so did our techniques. And also, though, the barriers to our stakeholders involved of authorizing and indicating surgery. So what changed my practice actually was back in 2009, where I was able to recruit Travis Matheny, and him and I knew each other when I was a fellow back at Boston at Mass General, and he had an interest in coming down to New York, and we just started this relationship. And it was great because not only it's just like what Shane mentioned, that when you have two surgeons looking at a patient together, because I couldn't send him up to his office in Boston. He had to come down to actually do clinic with us. Over the years, we learned tremendously, and it really just broadened my practice. And we didn't adopt the combined hip scope PAO right away. This took a little bit of time, but I'm glad it did, because after a few years, he really refined his surgical technique, and so did I. And so it would help with the decision-making of what to do with these types of patients and what we can offer them. And I think the most important thing, actually, in this day and age is we got to really show value creation of what we do. And this is a good paper that was done by Moed Diab with Kevin Bozic, and showing that there is cost effectiveness with just doing a PAO. Now, this is important as you indicate for insurance verification about noting the tonus grade, because they're going to ask for this. And you can see this drops in their study tremendously by just tonus grade 2. And then Chad Mather did a great job as well, even showing higher cost effectiveness with just doing FAI arthroscopic management. So, well, how do we look at this? Because this article that came out to me is really important, because it really showed back in 78 when Poncetti really described this about where we see these variations of the socket. And if you think about this, it makes sense, right? You have interstitial growth, provides the depth, oppositional growth provides the periphery, and you can get new bone formation in the periphery at the margin. Well, we wrote this paper up just to show the variations on acetabular rim disorders, and you can see this variation, these variations can occur in combination. So one of the studies that we looked at for my practice was just looking at patients coming in with a subset of borderline hip dysplasia with subspinous impingement. And we compared it to the cohort of FAI patients, and no surprise, they actually did well. But I look back at my study and I realized that, wow, our femoral version on this cohort was actually pretty low. So I think it was more that we're treating the subspinous impingement more than just any borderline hip dysplasia. That's why when we look at these articles, it's important to really look about how we define borderline dysplasia or not. So I like this study here, and this is from John Corsi's group back, I think he did this in 2013, and they looked at the histologic and characteristic molecular characterization of the impingement zone. And this showed some calcification in the reparative zone, subchondral bone. And this gives us some idea about, start to look at what's happening at the impingement zone. And then if you add some compromise on the acetabular rim, how is this leading to OA? So we actually did our own study too as well, and showed on patients undergoing FAI arthroscopic management, we looked at not only the histologic but the molecular analysis, and we had similar results in that there was increase of inflammatory markers. But what we also found that there was cell senescence. This is a new hot topic now in this field, showing that there was low cell proliferation, low apoptosis, and we also saw a distribution of age. So anyone age over 40 had increased loss of potential for tissue regeneration based on the markers, but increased inflammation and tissue destruction. Now, I like this other paper too by Professor Gons, who put this back in 1999 to talk about acetabular rim syndrome. What he's describing is about how do we get some of these rim fractures or os acetabuli. So we correlated that if you had incongruency, you had a shear fracture biomechanically, and this can lead to a vertical stress fracture, versus a congruent where you can get what we call an os acetabuli. So this is one of the cases that we just look histologically at this on one of my patients. We show that the characteristics around convex lateral, concave lateral, and convex medial, and you can show a clear delineation between the cartilage and the osseous portion. So as far as what I was charged to talk about is rim preparation for this. And most of the time we're trying to minimize our surgical time, especially when we do a combined hip scope PAO. And a lot of the times I'll do any of the rim work off traction. And also I like to just see about how much rim, because we're careful not to do any rim resection. The challenge has become about putting a suture management, as you particularly can see, as a more degree of hip dysplasia that there is. And there's options that we've learned and developed over time of managing these, but just like was said before, now this is a hypertrophic labrum, but most of the patients that when we do a combined hip scope PAO, most of the patients that I see do not have a hypertrophic labrum. This is another case of a hypertrophic labrum as well, and this is what happens. Me personally, though, I like to use the labral base fixation as Ben Dobin described, because I feel that this is a very floppy labrum, and I like to try to get stability and avoid any eversion. This is another patient that had an opposite problem that was also indicated for a combined hip scope PAO, but you can see this patient actually had a hypoplastic labrum. So not all cases are with hypertrophy seen. Now this case, I present this case here because this was a patient that had both bilateral symptomatic hips, and we had to decide on which side to do first. This patient's CEA angle is 18 on one side, the other side is 19, and tonus angle of 12 and 13. And you can see also our false profile view. She's also undercovered with an increased angle inclination. So this is my setup that we use. We start with just the normal hip scope setup, but we do a block beforehand. We try to minimize, because I learned from what those guys do at Boston Children's of regional anesthesia, to minimize the time for discharge, because what happens is that they get behind after when you do this combined procedure. So I think a regional block really is effective and helpful. You just got to partner up with the anesthesiologist to do this. And then this is another thing after the hip arthroscopy procedure. This is Travis actually checking the motion. And you can see this patient actually was at flexion at 90, was getting obligatory abduction and also some external rotation too. And this is after the arthroscopy. So we know that he's got to do some anteversion to get that flexion better. And now I prefer to do this dry because, like as what was mentioned earlier by Thomas, that we try to keep things dry, you try to minimize fluid extravasation, because when you get to this stage of the procedure, where Travis is, this is where you see a lot of fluid extravasation. This is what you want to minimize for them. And over time, we've gotten better at this. It also makes it a better dissection for Travis. Now, this patient also had this unstable portion of the os acetabuli. There's a great case example that Joel put in that this thing can actually heal if you just leave it alone. But since we were there, we actually took it out. And then I like to try to use smaller anchors in there and close to the rim to minimize any eversion of this as well. And then I think that a stabilization with multiple suture anchors, in case you just don't want to go back and think about a re-tear in that. But as far as stability of the labrum, we're also looking at restoring the seal of the socket. Now this is her post-operatively. And case number 2, this is again, everyone's reporting about a dancer, but this particular dancer is 18 years old, and she was an apprentice for a well-regarded company in New York City. And it was really a challenge of what to do at this point because she was just offered the contract. So she had left hip pain for the past over 6 months that just progressed on to daily activity. And this is her 3D CAT scan showing also anterior coverage, lack of coverage too as well. So we did a combined procedure on her. Hypertrophic labrum. She also had a partial tear of the ligamentum teres. We did a femoral osteoplasty on her too. And then this is her after 14 weeks. We had to take her screws out because she was so thin, it was just holding back her rehab. But she took a long time to get back, and that's Michelle Rodriguez. As some of you may know, she's a well-regarded physical therapist in Manhattan because this is the patient doing arabesque. Now, it's simple for us to say, well, you're a dancer, you got instability, you're hyperlax, just get a combined hip scope PAO, but this is her livelihood, this is what she needs to do. So we're very careful about our correction, about how much correction we're going to give her to maintain her motion to able to do this and perform on stage. Case 3 is an example of, we just did this past month. Now, this patient is 31 years old, has this hip that's been bothering him progressive for the past year, but he's got a BMI of 30. So he was indicated for surgery. How many of you would do a combined hip scope PAO on this patient? Well, that's good to hear because we just did the PAO. I just had Travis do the PAO on this. I don't think this is a patient that would try to attempt to do an arthroscopic combined hip scope PAO on this patient. First of all, it's challenging. It's also challenging for the surgeon doing the PAO. And I think with this amount of correction needed, he'll probably do fine with this without going inside his joint. The last case I'm going to show you is just a patient that actually we did, she is at that time we did our index procedure. She was 18 years old, but this is her post-op after a year. She's still having pain. We did an IA injection. She was having pain just past 90 degrees of flexion. And at this point now, we're thinking about now doing a revision procedure. Now, at this stage now, her center edge angle is 18 degrees, tonus angle was 9 degrees, and ACA was 30 degrees. So at this point here, how many of you would just proceed with a revision PAO or combined hip scope PAO or just do a hip arthroscopy? How many of you would just do a hip arthroscopy for this next part of the procedure? Anyone would do a revision combined hip scope PAO? No, okay. Well, we first did the hip arthroscopy because we wanted to make sure that she didn't have any capsular adhesions, which she did not. And then we refixed her labrum tear, that she had a recurrent tear. And then 6 weeks later, then we had Travis do the corrective osteotomy on her and improved her coverage now to 22 degrees, and she's doing better now. The last thing I want to talk, just quickly mentioned about capsule management. Now, when we do these with the combined procedure, I really try to keep this close to femoral head. Now, part of this is because a couple of times during the combined procedure, where my sutures got knocked out, we think from the osteotome, but I don't need the PAO surgeon critiquing my capsule of repair, so I tend to do it more laterally, kind of hide it away from his visualization. But more importantly, though, I think that's important to actually have good capsule management. I don't ever do a T-capsulotomy in these procedures, just like Thomas mentioned before, to really stick to an interportal capsulotomy. And this is one of our residents now, he's in practice now, Brian Walters, who did this nice study anatomically showing about where these structures are for the capsule. Now, the glutaminis and the ilocapsularis, these are dynamic structures that happen, so you need to be mindful of that especially when you're doing an interportal capsulotomy. So in the future, I think that it's important for us to establish value creation for when we do these procedures, as we start to get more strict on authorizations. Number two, what I like to see is some more advanced techniques to minimize our time in the surgery, and hopefully look at, I know Dante Parati is doing this as outpatient surgery. I know that's a challenge to do, but I think we can get there, and hopefully partner up with the regional anesthesiologist too as well. Thank you.
Srino, up next we have Dr. Neppel talking about